Stanford University.
I'd like to thank everybody for coming tonight. What I'd like to talk about tonight in the lecture is latest advances in vision correction procedures. So refractive surgery encompasses all surgical procedures that have the goal of allowing patients to see well without the use of glasses and contact lenses. And most of these procedures work by altering the shape of the cornea, which is the clear front surface of the eye. The era of modern refractive surgery was introduced about 25 years ago with the advent of excimer lasers. And on the slide bottom here, we see a modern excimer laser which we use today to perform LASIK and PRK procedures. This technology works by precisely removing tissue from the surface of the cornea, and that's the mechanism of action. One of the properties of this laser is that it's a cold or non-thermal laser, and this allows it to precisely remove tissue without causing any collateral damage to the tissue surrounding the area of interest. In the slide on top, you see a human hair with a scanning electron microscopy, and basically there are these little notches that have been etched into this hair using an excimer laser. Each pulse of excimer laser removes approximately 0.25 microns of tissue, so it's extremely precise. And one of the things you'll note is that there's very little damage to the tissue that hasn't been treated, and that's the property that makes it unique for corneal surgery. And I'll talk a little bit more about LASIK and PRK, as these are the most commonly performed refractive surgical procedures in this day and age. So there's a laundry list of refractive surgical procedures. The most common are wavefront-guided LASIK and wavefront-guided PRK. And many of these devices have been tested at Stanford and led to their approval. One of the more exciting areas in ophthalmology today is the advent of femtosecond laser technology. And this is a novel technology which has been introduced in the last 10 years, and it's been widely adopted for use in refractive surgical procedures and as increasingly in corneal procedures, and most recently developed for cataract surgery. The actual femtosecond laser technology for cataract surgery was developed at Stanford, and we'll talk a little bit about that later in the lecture. Not everyone is a good candidate for laser vision correction, LASIK or PRK, and these patients can be helped with something called phakic intraocular lenses. These are thin lenses that fit into the front portion of the eye, and I'll talk a little bit about that. And these were tested at Stanford, which led to their approval. There's also something called conductive keratoplasty, which I won't spend too much time for, but some of these trials, first-in-human treatments as well as the clinical trials, were performed at Stanford. And there are also topography-guided LASIK is another technique which was first used in the United States at Stanford University. And lastly, something called corneal collagen cross-linking for corneal ectasia and keratoconus. This is not a refractive surgical procedure, but it is a new procedure which has been developed for this disorder known as keratoconus, and it's filling an unmet medical need, and we'll talk a bit about that, and some of the advanced generation technologies being developed at Stanford University. So the thing I'd like to spend a little bit of time on first is wavefront-guided laser technology. Many of you who have had friends or family members who've had laser vision correction may have heard the term wavefront-guided or custom technology. And this is the most commonly performed excimer laser surgery these days. And what wavefront-guided laser technology is you use a wavefront measuring device, which is an automated non-contact laser device which objectively measures standard refraction. So that would be nearsightedness and astigmatism, as well as higher order aberrations. And these are micro irregularities in the eye, which are not typically measured when you go to the eye doctor and you look in that machine, which is called a phoropter, which they say, which is better lens, 1 or 2. This data then is sent to the excimer laser, which produces a customized laser vision correction procedure. And what the wavefront-guided laser is designed to do is to eliminate lower-order aberrations, which are nearsightedness, farsightedness, and astigmatism, as well as higher-order aberrations, which are these micro-irregularities of the optical system. And this will allow for the possibility of supernormal vision. So in the slide on top, we see a grid pattern which is passing through an optical structure. As it passes through the optical structure, the grid pattern is deformed by these micro-irregularities or higher-order aberrations. If you can design a pattern to go on the front of the optical, the eye, in the case of a human, to neutralize these micro-irregularities, you can see that the grid pattern in green is now projected through more perfectly without this distortion. And this will allow for better vision as well as potentially a supernormal vision. And this is really the goal of incorporating wavefront-guided technology in laser vision correction. So clinically, the way it works is you go in and you put your head on this device on the slide top left, and you look into this little aperture, and a non-contact laser beams through your eye, and it makes measurements. These measurements are then sent to the computer, which performs an analysis. It looks at nearsightedness, farsightedness, and astigmatism, and then it designs a pattern that eliminates your nearsightedness and astigmatism, but also takes into account these micro-irregularities of the eye, which you see this contour map. Then the data is then transferred into the excimer laser. And in this case, this is an eye that's undergoing LASIK, where you have a LASIK flap that's been created, which is the first part of LASIK surgery. And then using biometric scanning, the eye is precisely identified as your eye and which eye, left or right, and the pulses are precisely placed where they need to go to do this very precise treatment. And this is how the wavefront-guided treatment is performed. So this is an artist's rendition of what somebody with low levels of nearsightedness and astigmatism might see without their glasses on. And even though you may make out the 20/25 or 20/20 line, we see that anything beyond that is really very, very blurry and is hard to discern. If you correct nearsightedness and astigmatism or lower order aberrations, this is what you typically will get. You'll get a nice crisp 20/25, 20/20, but when you look at the letters beyond that, 2016, 2012.5, or 2010, they're really quite blurry. So there may be the potential for better correction. So if you incorporate not only the lower order aberrations, but you also incorporate in higher order aberrations, you may actually be able to get better visual acuity. And in this case, this would be an optimal case where now not only do you see the 20/25 and 20/20 lines, but you're able to see all the way down to 2010, and it's fairly clear. And this is the limit of human vision. It has to do with how closely the photoreceptors are spaced. So obviously the goal is, with these types of procedures, is to get as good a possible vision as you can. So the second real significant or revolutionary development in ophthalmology has been the advent of femtosecond laser technology. And this technology was developed about 10 years ago and widely adopted in the last decade, primarily for refractive surgery, creating the flap when you perform LASIK surgery. And I'll show some videos of that so you can see what I'm talking about. But it's increasingly been adopted for corneal surgery, and now more recently been adopted for cataract surgery, as I'll discuss in the lecture. So femtosecond lasers are a novel laser technology that can be used to perform corneal, refractive, and cataract surgery. They work at 1053 nanometers. It's infrared, and it's a rapid-fire short-pulse laser that at a very small spot size of about 2 to 3 microns. And as opposed to excimer lasers, which have precise surface effects, this has precise subsurface effects. The laser is delivered through tissue at a precise depth to create a flap in LASIK surgery or to fragment a cataract in cataract surgery, as we'll show you. So in LASIK surgery, the first step is to create a thin flap in the cornea. Traditionally, this has been done using a microkeratome, which is a mechanical cutting device with a blade that slices across the cornea. And this works quite well, but mechanical machines are not as accurate as lasers, as we all know. So the technique of using femtosecond lasers works by a process called photodisruption. And the way the technology works is the laser passes through the tissue to a precise depth below the surface. It causes a cavitation bubble, which releases CO2 and water. These cavitation bubbles will then coalesce together and form a cleavage plane, as we'll see in the video. So many thousands of pulses are put into the cornea very, very rapidly. The lasers work anywhere from 60 kilohertz to 100 to 400 kilohertz. What you see here, you have a cavitation bubble. Multiple bubbles will be placed at precise depth, and then these will coalesce and form a cleavage plane, and allowing you to create this precise flap at the precise depth you like. So in clinical practice, the way it's done is a suction ring holds the eye steady when performing LASIK, and then an applanation lens will drop down on the cornea, and the way the laser will place the pulses at a precise distance from the lens onto the cornea, as we'll see. And here's how it works here. So this suction ring will be lowered down on the eye, and then the applanation lens lowers it against the cornea, and now thousands and thousands of pulsars are placed below the surface precisely, and this will create a round flap which can be elevated, and then the excimer laser will be employed to reshape the underlying surface and eliminate the nearsightedness and astigmatism. So that's a artist rendition, but I'll actually show you a very fast video of an actual LASIK procedure. So the suction ring is lowered on the eye, and then the lens is dropped in. You'll see a little green light which will come on. This is for the surgical view, showing that you have achieved a safe docking. And now you see this whitening of the cornea.
Your video's not playing.
Oh, that's not good.
I can see it.
All right. I'm not sure why that's not working. It's on my computer. All right. Well, maybe it would disturb some people, but I'm just debating if I should. Well, you know what I'll do? Let me just run it again. I'll just turn it around, and you can see. It would be hard to see, however, but let me just do it so maybe you guys can see from there. I don't know how well you'll be able to see it, but we'll give it a shot. So it's okay, fair enough. So it lowers on. You'll see a little green light that comes on saying it's safe to do the treatment. And then what will happen is you'll see whitening as these pulsars are put in quite rapidly. It'll come all the way up the cornea. And this is actually an older generation machine. It took about 17 seconds to do this. We now have machines that do it in about 9 seconds. Not that we're in a rush, but you know, if you're having surgery, you'd rather have it get done sooner than later. So then what will happen is we'll take a little device and lift this flap, and this is the part maybe you won't like as much, but all the cleavage plane is formed, and we just go in there and sweep it out and elevate it and flip it back. Once it's flipped back, then we can apply the laser pulses underneath the surface, do the treatment, and then lie it back down. So the whole procedure to do a LASIK surgery takes under a minute and a half to do per eye, and it's completely painless, and patients return to normal activities generally the next day. Most people can drive their car, can go back to work on the computer, what have you. So it's really quite remarkable how quickly the recovery is. Okay, now everybody can see it. Maybe you're not seeing it now, I don't know. So that's the practical aspects of it. Now, what could somebody expect from this type of surgery? Well, using our modern wavefront-guided LASIK and PRK, what we find is in patients with low to moderate levels of nearsightedness, which encompasses most of the population, you get about 99.9% of patients achieving an uncorrected visual acuity without glasses or contacts of 20/40 or better, which is legal driving vision. If 98% 20/25 or better, and 97% of eyes at 20/20 or better, which is considered the gold standard. And one of the other things that's impressive is that 90% of the eyes that have surgery will see as well or better without glasses following wavefront-guided LASIK and PRK than they did with their glasses or contact lenses prior to having surgery. So patients will sometimes actually have their vision improved over what they could get with glasses or contacts. And that's really, the goal in as many patients as we can achieve it. And just as a comparison, when the excimer lasers were first introduced, we only had about 60% of eyes achieving 20/20 or better. So it's dramatically improved over the last 2 decades. So this is all well and good if you're a candidate for this type of surgery, but there is a very small subgroup of patients who aren't candidates for either LASIK or PRK surgery, and these are people who have extreme levels of nearsightedness. Ones where in grade school they'd be teased that they had Coke bottle glasses, and they just can't be helped because you have to remove too much tissue. And this is a technology that is well suited for this subpopulation. It's called phakic intraocular lenses. And what it is you insert a lens inside the eye in addition to the lens you're born with. In this case, you have a thin lens that's clipped onto the front colored portion of the eye, which is called the iris, and it corrects the nearsightedness and astigmatism. Typically, these lenses are used for patients with high degrees or extreme degrees of nearsightedness, 8, 10, 12, 14, 16 diopters, and it really works extremely well for these patients. There's another variance of these lenses in that it slips behind the colored portion of the eye, and these are two different types of lenses that are currently available in the United States. The results are quite good. Nearly 97% of eyes achieve an uncorrected visual acuity of 20/40 or better, and about 65% of patients achieve an uncorrected visual acuity of 20/20 or better. Now, if you compare this to the LASIK and PRK, you say, well, that's not as good. But you have to understand the results for LASIK and PRK were low to moderate, so about 4.5 to 5 diopters. These are individuals with highly nearsighted eyes, about -11 to -12. So it's not apples to apples. I mean, so it's a little bit of an unfair comparison, but they really works extremely well for this group of patients who really most benefit from laser vision correction, or from vision correction procedure. So I just want to shift gears a little bit here and talk about collagen cross-linking for keratoconus and corneal ectasia. Now, this is not a real refractive surgical procedure. However, it is a new technology that addresses a previously untreatable condition called keratoconus. So what keratoconus is, it's a progressive degenerative disorder of the eye which leads to a thinning and bulging of the cornea. I don't know how well it projects, but this is a cornea, and it's not usually this conical in appearance, and that's somebody with keratoconus. It affects about 1 in 1,000 people in the United States, so about 300,000 people. And the age of onset is usually in the late teens and early 20s. And the initial symptoms are blurry vision, which is not correctable with glasses or soft contact lenses. And most patients ultimately require the use of rigid gas permeable or hard contact lenses. So the primary non-surgical treatment is the use of rigid gas permeable contact lenses. And in advanced cases, these patients have to go on to have corneal transplantation. There is one other procedure, something called corneal intact ring segments, where you put these two small plastic ring segments in the eye, which helps flatten and regularize the cornea, but it doesn't address the underlying instability of the cornea with the progressive changes. So collagen cross-linking is a novel technology which has been developed to arrest the progression of the underlying disease process. And basically what it does is it uses riboflavin, which is vitamin B2, and it's photoactivated with UV light to cause a strengthening of the cornea. And it's been shown now, it was originally developed in Switzerland, and it's been shown now to out to at least 12 years to have good stability. The current surgical procedure is lengthy, as I'll show, and there's a prolonged recovery with a delay of return of visual acuity. And there's a mild to moderate pain for 2 to 3 days following the surgery. And as you'll see, the current technology is relatively crude. So the way it's done is the superficial layer of the cornea, which is the front curved surface of the eye, is removed mechanically. So you just scrape some of the cells off. And then you apply riboflavin, which is a yellowish green, as you can see in this picture, every 2 to 3 minutes for about 30 minutes to load the cornea with an adequate dose. Once you've had enough time for this riboflavin to diffuse in the cornea, then the patient is placed underneath this light for 30 minutes with this lovely speculum holding the eye open. So you might imagine that this is not the most comfortable thing to have done. And every 2 to 3 minutes, somebody has to drop a little anesthetic and as well as a little of this riboflavin because it gets consumed. So if you had keratoconus and you wanted to stop the progression and you want to avoid a corneal transplant, you do this in a heartbeat, but there's got to be a better way to do this. And we've developed a non-invasive technology at Stanford which allows a procedure to be performed painlessly with rapid visual recovery. We don't have to remove the superficial skin layer on the eye. There's no change or worsening in the visual acuity, so patients get off the table, have minimal change in their vision, and they're able to go back to normal activities the very next day. So we're planning to a multi-center FDA clinical trial in the fall of this year, hopefully, if not the first quarter of 2012. So it's exciting to be able to offer patients who've previously had untreatable condition with something that can arrest the progression. So the last thing I'd like to spend some time with is one of the more exciting things which is happening in ophthalmology, and it's femtosecond-assisted laser cataract surgery. And this is really sort of the hottest topic in ophthalmology. We're having a meeting in San Diego, and it's hard to get an ophthalmologist that excited, but about this, there's a real buzz about it, and I'll spend a little bit of time on this. So cataract surgery is the most commonly performed ophthalmic surgery in the United States, and I'm sure most of you know friends or have family members that have undergone cataract surgery. And even though everybody thinks they had their cataract surgery removed with lasers, that didn't really happen. But with this technology, which is just being developed, it will ultimately all be done with lasers. So a cataract is a clouding of the lens in a variety, the natural lens that we're born with. And in this case, you have a central cataract, which is cloudy. And what happens is, when you have a cataract, it blocks the light coming in the eye, and it causes blurring of vision. So here is a simulation of what somebody would see who doesn't have a cataract, nice crisp, and with the cataract you have blurring and distortion and change in colors. Once the cataract is removed and an implant is put in the eye, you go back to having good visual acuity. So there are a number of steps in cataract surgery that need to be performed. And this is how it's done currently, and has been done this way for the last couple of decades. There's really 4 steps: an incision, what's called capsular rhexis, which is an opening of the capsular bag, which contains the crystalline lens. And then there's a phacoemulsification, in which a probe is inserted in the eye and it chews up the lens. And then lastly, you insert an implant called an intraocular lens, and those are the steps. And so there are certain problems or potential problems with each of these steps. The first step is you create an incision in the cornea or in the white part of the eye, the sclera, and this is done freehand by surgeons and use a diamond knife or a metal blade. And the goal is to create what's called a shelved or beveled self-sealing wound. So when you're done with the surgery, the wound falls together and it's watertight without the need for any kind of stitches. But one of the problems you can get is if the wound is not properly constructed is it can leak and you can have infection, which is called endophthalmitis, and that can be potentially catastrophic. The second step is opening this front portion in front of the lens, and this is done with a bent needle, and I'll show you that. So you go in and you score this capsule, and then you're going to introduce another instrument called a forceps, and you're going to grab the edge of this and tear it around manually, hoping to make a nice round opening. And it's very elegant to watch from a microsurgical standpoint, but obviously there's certain things can happen when you're doing these mechanically or manually. So in this case, this would be a suboptimal opening in that you have this opening, it's not round, and it's not in the center, and I'll tell you why that's important. Or worse, you're trying to make this round opening, and it tracks back, and it rips the back part, which is called a capsular rupture, which is also not good. So there's got to be a better way to do this with more precision. Now, the third step is the phacoemulsification, which a probe is inserted in the eye, and using ultrasonic energy, the lens is chopped up and removed through suction. So especially when you're dealing with lenses maybe that are a little more advanced or more dense, you have to put a lot of energy in the eye, and that can have a couple problems. The extra energy in the eye can damage the cornea. It's something called the corneal endothelium, which keeps the cornea clear and doesn't allow it to swell. And you can generate heat when you're doing this. And in this case, you actually have whitening here, which signifies a thermal injury to the cornea, and that can lead to problems with the wound architecture and cause a leak and lead to infection. So the last step is inserting the lens, and this is usually put in through a foldable device. It's like a pen cartridge. It just slips in and it unfurls in the eye. But one of the things is if you're using some of the more advanced lenses like a multifocal lens, which has concentric rings, this is distance, near. With these lenses allow you to focus it clearly at distance and at close. But one of the properties of this lens is it has to be perfectly centered, or you're going to end up having untoward visual symptoms. So you can see, in this case, because the capsulorhexis was not perfect, now you're looking through a decentered lens, which causes all sorts of visual phenomenon. So the objectives of using femtosecond lasers in cataract surgery are to increase the safety, improve precision, improve reproducibility, especially surgeon to surgeon, and to standardize the procedures. And I'll go in through this a little bit. So this is what's called an ocular coherence tomography. It's taking the eye, and what you're doing is, I'll just borrow this. This would be looking at the eye in cross-section if you just went right in half, so that you'll see the cornea is this part here, and then here's the lens, which gets cloudy, is called a cataract, and this is the front part where you're going to create the opening. This is the device, the femtosecond device. It has very sophisticated imaging and scanning abilities, so it's able to place the laser energy exactly where it needs to go in real time. So I'm going to show you actual, I may have to turn this thing around, but let's see. Okay, so again, the first part is going to be this opening in the front, and I'll try to be neutral and put it in the middle here. You'll see this little round circle forming, and that's the cutting the capsule in the front. Then you'll see it'll divide the lens into 4 pieces, and it'll cube it into very, very tiny cubes. And one of the things you'll see is it releases bubbles. Those are CO2 bubbles from the femtosecond flap creation. I'm sorry, from the femtosecond cavitation bubbles. And then at the end of the case, it's actually going to create the incision for us. So this is in real time, so it's very, very rapid. It takes less than 45 seconds to do that. And then you're going to see over here, this is actually the incision being made. And this can be placed in any configuration. It can be made in the same place over and over again without very much variability from surgeon to surgeon. Now, after this, this is a little thing. We leave a little tissue bridge because it's in a different room, and you bring the patient into the other room. So you just break that little tissue ridge. You pull out that little opening. It's just a little, it's almost like saran wrap. You pull it out, and then you'll insert this little probe that will go in and chew up the lens. And it breaks up very nicely because it's been fragmented into these little cubes. So you don't have to put a lot of ultrasonic energy in the eye as you would normally with a formed lens. And that reduces the amount of energy in the eye, so you have less damage to the endothelium on the cornea, and you have little or no risk of causing a thermal injury to your incision. And most of this is being removed just with what's called aspiration. It's just sucking it out without having to put energy in the eye. I think that's my last video, so I won't have to hold this thing. So this is so the femtosecond laser can be programmed in any configuration you want, and we use many different types when we're doing corneal surgery for corneal transplants. What you want to do when you create a cataract surgery is do these beveled self-sealing incisions. And this is, again, a ocular coherence tomography. And over here is the incision, and it's very well opposed. This is post-operative, and you can see that little white area, which will be highlighted in yellow here. And it makes a beautiful incision without having to rely upon a manually made with a diamond blade or a metal blade. The other thing you get is you get a very consistent, perfect opening each time. When you're trying to create a 5-millimeter opening, you're within 27 microns of your intended correction, as opposed to manual, which is about 383 microns in diameter. And this just shows the yellow is the opening in this capsule, and this is the lens that's been put in green. And it's just perfectly centered, which, as I showed earlier, is very important. And this just basically shows a laser-created opening on the slide right and a manual on the slide left. And you can see these openings, which are highlighted by the arrows, are very round and regular from the laser, but are very irregular on the mechanical or manual. So the advantages of femtosecond lasers are that it improves safety, increases precision, and enhances reproducibility, especially from surgeon to surgeon, and also allows the possibility of customized surgery. The disadvantages are the increased cost. These machines are quite costly. They range from about $400,000 to $500,000, and they add extra surgical time. You now need to take the patient from the femtosecond laser, and then you have to transfer them into the operating room and complete the case with this suction phacoemulsification. So hopefully these issues will be addressed as we go forward, but it really represents a major advance in how cataract surgery will be performed. So I'll conclude with some of the future developments in cataract and refractive surgery. As we've seen tonight, the fields of cataract, corneal, and refractive surgery are rapidly advancing, and the advances are improving outcomes in cataract, corneal, and refractive surgery. There is ongoing research into other areas, especially to address presbyopia, which is the need for reading glasses over age 42. This is a huge need for this, as everyone who's over the age of 42, 44 would like to be able to read without reading glasses, or almost everyone would like that. With cataract surgery, there are newer, truly accommodating lens implants which allow for the full range of vision in patients having surgery. When you have cataract surgery, now you basically choose between 3 lenses. You can choose a monofocal lens, which fixes your vision perfectly for distance, or you could choose a multifocal lens, which I showed earlier, which has these concentric circles. A monofocal lens gives you the highest quality vision, but you have one focal point. You have distance is good. You're playing tennis, driving your car, but for computer and reading, you need a pair of glasses. The multifocal lenses allow you a much wider range of vision, but they're not well accepted by every patient. It can cut down on the quality of vision. Some patients have symptomatic glare and halos. And there are other lenses that have a bit of an accommodating principles where they try to mimic what the natural lens does by moving back and forth, but they're really early iterations. And there are some new things in the pipeline that really hope to get us back to what our crystalline lens does and allow us a full range of vision. And probably the most important thing, at least from my perspective, is the technology being developed to help address complications in patients that have previously undergone corneal cataract and refractive surgery. That's really a lot of work's being done, and I really think that this is something that there's a great need for. So I'll finish it up there. I'll open up the session for any questions, and I'd like to thank you for your attention. So I'll repeat the question so everybody can hear. So the question is, can I elaborate more on the treatments that are coming online for presbyopia, and is it better to wait now? Otherwise, will having a procedure now preclude you from having some type of surgery down the road? So when looking at laser vision correction, the only way, if you're over the age of 42, 44, 45, to preserve distance and close is to do something called monovision, and that's where you set one eye for distance and you set the other eye for close. And some people do this with contact lenses, and if you like it and you can try that in contact lenses, then that's something you could do with surgery. But not all patients like that. So it's a compromise solution. On the good end of it, one eye sees great at distance and the other eye sees well at near. On the flip side, though, one eye is not good at distance, the other eye is not good at near. So, some people can tolerate it. It's probably somewhere between 15 to 20% of patients like it, and the others just choose not to do that. There are some technologies coming probably over the next several years. Some of them can still be done even if you had LASIK or PRK surgery. One of which is what's called a corneal inlay, where you actually put a very small plastic disc or silicon disc. It's actually I forget the exact composition, but it's a very, very thin insert under the LASIK flap, and it acts as a pinhole effect. So it doesn't degrade your vision at distance. There's a slight degradation of distance vision, but it gives you good close vision. And this is actually wending its way through the FDA right now and has shown very good results in the short term. But time will tell whether that actually works out. If you're having cataract surgery, I think there are significantly better lenses being developed. There's a number of them in the late-stage FDA clinical trials. Obviously, if you have a cataract, though, it's different than having laser vision correction, because cataracts impair your vision, and if you can't see, it's not like you can wait around a long time. So in that case, you just have to have a conversation with your ophthalmologist as to what the best option is in your particular case. So the question is are there any technologies that have been developed for floaters, and which are, we call them nuisances as ophthalmologists, but I have some floaters, so I know they're more than a nuisance. So and people who are highly myopic tend to get that more commonly. So it is quite bothersome. Sometimes you'll get a significant floater that's just right in the vision, and it's very distracting. You can interfere with reading and things. And there are some technologies that have been tried. There's nothing really currently available that's sort of accepted as a safe and effective procedure. But there are a couple companies that are working on that. There's a couple in Europe, and there's one or two in the U.S. I don't know exactly where they are on the approval process, but I would say, you know, that's something that would actually, there'd be a fairly big market, and probably will come available in the next 3 to 5 years. Could be much sooner, could be much later, though. Question back.
Are there any new advances in ocular degeneration?
The question is, are there any new advances in macular degeneration? So there have been in the last several years. The biggest advance is the use of something called Lucentis and Avastin, which inhibits blood vessel growth. And before that, there were very few drugs that you could do much about. So these drugs halt the progression, and in many cases, you'll actually improve the vision to some degree. It depends on the type of macular degeneration you have. There are some forms that there's nothing you can do about currently, and those are obviously that's a very difficult thing to deal with because it's a steadily progressive disorder and you just slowly lose your vision. There's a lot of work in retinal implants and retinal chips, but that's really at its earliest stages. But if you do have macular degeneration, it really is worthwhile to see a retina specialist and see if it's the type that can be treated with these Avastin and Lucentis drugs. Yes, the single most common side effect of LASIK and PRK surgery is an increase in dry eye symptoms. If you look in the short term, in the first several months, it's about 30 to 40% of patients will report they have dryness, worse than they had prior to surgery. If you go longer term, a year and beyond, it's about 5% will say that they have persistent long-term dryness. So that's the single most common side effect of these procedures. There is a variety of technologies that you can use to try to treat that, but that's one of the more difficult things if you end up with the dryness after the surgery. So the question is, her son is 19 years old and is interested in laser vision correction, LASIK or PRK, and when is the eye stable? It depends on a variety of things. The only way to know for sure is to measure your vision every year. When you're 62, say, oh, it's stable at 20 or it's stable at 40. Obviously, that's not that practical because we can't go back in time. If you could invent that contraption, you'd be okay. But it depends on how nearsighted he is and what his history has been. 19 is really is on the earlier side. Most people tend to stabilize in their mid to late 20s. So the FDA, most of the lasers, their labeling says age 21 and over. So if you do somebody at that age, there's a very, very high risk that they'll have progressive changes, increased levels of nearsightedness and astigmatism as they get older. That being said, there's two schools of thought. One is if you do people when they're younger, a good percentage of them will stay stable longer term. But then a higher than average percent will get regression or progression of their nearsightedness. What you can do with both LASIK and PRK is you can go back and do a reoperation years later and fix that. So, you know, there's two schools of thought. One, wait till you're stable and just do it once and hope to stay stable. Or if you did it early and with knowing that you're going to potentially need to have it done again at 10, 15 years down the road. I tend to like to have patients be stable. I have done patients as young as 18, 19, 20 who are, you know, maybe they're soldiers and they're going off to war and they, you know, for a variety of reasons they can't wear glasses and contacts aren't practical in a desert arena. Also, Division I ball players, water polo, it's very hard to wear glasses and contact lenses in the pool are not safe. And you know, many of these patients were treated when they were 18 or 19, and I've been doing this for over 17 years, and I see, you know, a lot of them come back and they're still stable in their 30s. So Some of them, though, do require retreatment at a much higher rate than you'd see in a population that was, quote-unquote stable, if did some in their mid-20s or mid-30s. If you and the father are both very nearsighted, and your son is -3 and he was -2 last year, that's not really good. He's probably going to keep changing. So there's a variety of things that go into calculating that. Yeah, anytime you do a surgery, there's risks associated with it: infection, inflammation. But it's done quite commonly. LASIK and PRK have an enhancement rate, a retreatment rate of about 5% on average. So 1 in 20 patients will go back 3 to 6 months after having their original surgery and having a follow-on surgery to get them closer. Because if you go and have LASIK or PRK and you're 20/40, yeah, legal driving vision, but you really wouldn't be happy with that. You'd want to see more clearly. So the vast majority of people, because you're going through the time, the risk, the expense, want to see as well as they can. They don't want thinner glasses or thinner contact lenses. So we do it quite routinely, and the risks are, they're real, but most of them are quite manageable. So the question is, we saw how nice the results look, but what's the downside and what are the potential complications of LASIK and PRK? The surgical complications of LASIK are related to the flap creation. Using a femtosecond laser, the complication rates are somewhere between 1 in 5,000 and 1 in 10,000. With a mechanical cutting device, with a blade, it's somewhere between, depending on if it's an expert, experienced surgeon, it's probably 1 in 1,000 to 1 in 1,500. Most people are switched over now to the lasers because of the lower complication rate. You can have an infection around the time of surgery. The rate is probably about 1 in 2,500, and that would be like a serious vision-threatening complication. With PRK, there's no flap, so there's no flap complication risk. The main risk is the risk of developing corneal haze or scarring, and that risk is about 1 in 1,000. But if you develop that in the majority of cases, you can treat that. One of the more devastating complications would be something called ectasia, what I mentioned using the collagen cross-linking, and that's where you get a weakening of the cornea from the LASIK or PRK, and it bulges forward. And now you no longer can see well without glasses, and you require hard contact lenses. It's quite rare, and now that we have collagen cross-linking, people have shown that you can arrest the progression of that. So we try to avoid that at all costs, and it's probably less than 1 in 10,000 cases. But these are not surgeries without risk. I mean, the safest thing to do is to wear glasses. The next risky thing is to wear contacts. The next risky thing is to sleep in contacts. And then finally comes these laser vision correction procedures. I think they're safe and effective, but they're not for everyone, and everyone has a different level of risk tolerance. And each case is individualized, and you need to really discuss that with your eye care provider. Well, I think we're out of questions. Thank you very much.
For more, please visit us at stanford.edu.